My name is Claudia Ellison, Director of Programs at eHealth Initiative, and I want to welcome everyone to today's webinar, Digitizing the Consumer Healthcare Journey. We're really pleased to have some fabulous speakers talking today. It just seems that the expectations of consumers these days is to be able to do everything online. The patient experience is definitely going digital. And to improve patient engagement and customer satisfaction, the healthcare organizations need to keep up with this demand. So today we're going to hear from both Aaron Martin, who's the Executive Vice President and Chief Digital Officer of Providence St. Joseph Health, and Gardner, who's the co-founder and CEO of Kyruus, who's going to share with us the innovative technologies that they have joined forces together to conduct at Providence. And you can please ask them many, many questions of how they got started and how things are going so far to improve the patient experience. So, but before we get started, we've got a few housekeeping tips. All the participants are muted. In order to ask a question, you'll see on your screen that there's a chat box. There's also a Q&A box. And so for the chat box, if you have any technical difficulties, please use the chat box. But for the questions, please use the Q&A box. And this allows us to, once the webinar is over, if there are any additional questions, we can respond to them. And it just helps to keep all the questions in one location. And we'll remind you over the course of the webinar. The EHI mission is, we're all about convening executives from across stakeholder groups, bringing together key players to focus on critical issues that need to be dealt with to transform healthcare. As you can see, we've got wonderful members across all demographics of payers, providers, vendors, consultants. If you're interested in being at the table with us and helping to transform healthcare, I strongly encourage you to get involved with us. And in fact, today our presentation includes one of our members from Providence St. Joseph, and we want to thank our members. And we love to provide opportunities to highlight the innovative work that our members are doing. In terms of the eHealth Initiative areas of focus, we have value-based care, interoperability, privacy and security, and analytics. These are the 4 areas, and we have task force meetings that conduct the work and best practices for these areas. All the work that we do is saved on our EHI resource page. Take a look when you get a chance. We've got wonderful, wonderful information. And even though some work that's not conducted through EHI that people want to make sure that people see, they can submit through the link on our resource page. So if you've got white papers or research that you'd like people to see, please don't hesitate to add this to our resource page. And on that note, I'd like to turn this over to Aaron Martin and start the program. Aaron?
Hi, thanks so much. I'm Aaron Martin. I'm the Chief Digital Officer for Providence. We're based in Seattle. We're a $25 billion health system. And just, by way of introduction, my team owns 3 things for the health system. The first thing is our digital organization. So that's anything that's consumer or patient-facing in terms of our digital interfaces. So think our website, our apps, how we interact with the consumer. Second thing is my team also owns marketing. So we own our brand marketing, our digital marketing, and our service line marketing across our health system. And the third thing is our venture fund. So Providence Ventures, which is a $300 million venture fund, and 17 portfolio companies. So the problem that we're kind of facing as a health system is that commercially insured patients are in the driver's seat these days. They fund our health system's mission. So we're a mission-based organization. We focus on serving everybody in the community, especially the poor and vulnerable. But we can't do that without securing our commercial patient base. There's a big cross-subsidization that happens in healthcare where commercial patients typically pay between 140 and 150% of Medicare, and Medicare and Medicaid are kind of, at best, on a good day, Medicare is break even, and Medicaid, we lose money. And so we have to build a great value proposition for all of our patients. But what we found is our commercial patients are especially, A, becoming kind of free agents with plenty of choice, and B, demanding digital convenience and access. So they're becoming more and more digitally enabled. The next slide. And so health systems haven't been keeping pace. And so if you look at kind of what consumers want, they want, the same thing that they see in the rest of their digital life, whether it be on Amazon, Netflix, Lyft, et cetera. They have specific expectations that they have. They want it, where, when, and they want their health care where, when, and how they want it. They want it to be affordable. They want it to be transparent. And they want it to be digitally delivered as a proxy for convenience. The reality with most health systems is they're still kind of operating in a best case scenario in the 90s. You have to phone to make an appointment. There's a long wait times for primary care physicians. The pricing is complex. Information is siloed, and the care can be fragmented. So my team's focus has been to kind of fix that for our health system over the last six years. The other thing too is that we're also I like to say we're in a tough neighborhood here in Seattle. I'm literally looking outside of my office, and I can wave to my friends over at Amazon Care. They're over there working on, a great solution for their employees. And then on the other corner, literally a block away, is 98.6 with Robbie Cape and team, who are working on a great solution for employers and payers. And then we've also got kind of traditional retailers getting into primary care as well. CVS Health, for instance, has announced that they're going to build close to 1,500 clinics across the United States to support their members and also to provide primary care. Next slide. So with all that kind of background in terms of this, when you kind of boil it down to a very, very basic level, there's three things that consumers are searching for online when they're looking for health care. The first is they're researching a condition. And in that case, they're looking for kind of branded, reliable, personalized content. They want credible clinical content. They want diagnosis bots. They want to really understand, what do they have, or do they suspect they've got a condition they're interested in kind of researching. Then once they're kind of ready to transact, there's really kind of two ways that they think about it. First is they've either been kind of, required to select a PCP, a primary care physician, from their insurance plan, or they've been referred to a specialist. And so in those cases, they're looking for, obviously, things about the physician. Is this person going to be the right primary care physician for me? But also their insurance, their qualification, their scope of practice, and obviously something about quality, for that physician. In same-day care, they're looking for something done in the next kind of 12 to 24 hours. So they're looking for immediate service. It's, it can be low acuity all the way up to high acuity, obviously for EDs. And in that case, they're really focused on a trusted brand, location convenience, and the scope of practice of the site. So today, what I'm going to primarily talk about, with Graham's Health is the transaction portion of what we're talking about, but the content and the research piece is equally as important to a health system as well, and perhaps we can kind of come back and talk about that at a later date. So go ahead and advance the slide. Keep going. So this is Providence's digital platform at a super high level. So at the highest level, we have got a lot of technology that engages with what we call digital aggregators. So, primarily Google, a little bit with Amazon, a little bit with Apple. And then we basically draw them into our website. And then effectively, you've got kind of two big solutions. On the one hand, for physician search and match, we've got Kyruus, who is the company that Graham leads. And then on the same-day care platform, we've actually invented a company called DexCare that delivers an integrated same-day care experience that I'll go to in depth after Graham speaks. And then once we've kind of captured the patient, if you will, on the website and through these kind of transactional platforms, then our goal is to engage them closely. And so we've launched effectively a digital front door app called Providence Health Connect. And the way that we drive engagement is through personalized content through a company called Wildflower Health, which provides clinically approved, content for kind of the day-to-day health care of our patients. And Zelf, which is a third-party prescription platform that allows a physician in clinic to prescribe anything that's not a pharmaceutical. So in the same way that you would prescribe a pharmaceutical directly from the EMR and go pick it up at your drugstore, what Zelf allows us to do is prescribe anything that is not a pharmaceutical. So say a knee brace, an app, content, an article that the physician wants the patient to read can be prescribed directly from the EMR, and then they pick it up in our digital front door application called Providence Health Connect. So with that, I'm going to hand it over to Graham to talk a little bit about Kyruus.
Great, thank you, Aaron, and thank you, Claudia, also for including me in this. By way of background, I'm a cardiologist by training, but I spent the last decade or so working at the intersection of healthcare and technology, and now serve as the co-founder and CEO of Kyruus. Kyruus helps manage the provider directory as well as the routing and scheduling for about 250,000 providers across the country and about 600 hospitals. And I thought I would start on this first slide really by talking about some of the themes that we hear from health system leaders as we're engaging with them across the country. The first, and probably the reason that we're all here today, is that consumerization is finally here. We've been talking about it for over a decade, but I think in particular, the digital channel has opened up shopping to consumers in a way like never before. And they're looking now for the same kinds of features and functionality that they expect in travel and in banking and things like that. What I think is challenging, though, for health systems here in the second bullet point is that it's not kind of an overnight switch to an all digital. And I think the reality is that for some time to come, patients are still going to be getting names of specialists from their primary care doctor. They may go online to do some research, but many of them are still going to feel comfortable calling into a call center and wanting to ensure that the appointment is booked there with a person. And so one of the things that we talk about, and I'll dig into a little bit as well, is that those really have to be a consistent set of data so that the patient doesn't get confused if profiles are shifting from one of those access channels to another. And the final two trends that I think have also been complicating have been, on the one hand, the consolidation of health systems. So organizations are coming together, merging practices, sometimes across very large geographies like Providence in the Pacific Northwest. At the same time, medicine is becoming increasingly super subspecialized. And so gone are these days where we all hung out together in the physician lounge and you had a go-to ortho guy that you would send all your cases to. There's now a hand specialist, an elbow, a foot and ankle, a spine, elbow. And knowing who is actually in the network, much less is available sooner, or it might be a female that speaks Spanish, has become increasingly difficult for providers. And so I think that's why we're seeing a lot of the inefficiencies and leakage out of network across the country. So Claudia, if I could ask you to go to the next slide. So just to double click there on the consumer-driven healthcare. Oh, sorry, if we go back one. I think it's very clear that many patients actually have a strong affinity for online booking. And in fact, when they're surveyed, half of them would be willing to switch providers for that option, something I just found absolutely astounding. At the same time, it's not just for kind of the initial booking, that many of them are looking to come back and optimize their schedulability. I remember a conversation that I had with a leader of a cancer center when they had first taken a schedule online. And they actually been quite surprised to see so many cancellations and reschedule happening after doing so. But when they dug into it, what they realized was that these patients had an initial appointment with a provider, but were really desperate to get in. They have a diagnosis like cancer, and so they were actually self-shopping and curating the schedule to try to get in sooner. And they realized it was in many ways a win-win. The patient was obviously getting in sooner, and they themselves, all their schedules were being filled as well. So that was very exciting for them. And then finally, I think what we're seeing, and I'll let Aaron touch on even more toward the end, is that location and the convenience, excuse me, of location and hours are becoming now synonymous with quality. And for many conditions, being able to be seen down the street today for $10 trumps just about anything else. And so being able to kind of accommodate those kind of searches and that kind of urgency is also going to be critical. So Claudia, you can go to the next slide now. As I was touching on, I think that the challenge for health systems, though, is how they integrate the digital channel into all of the other access points that patients are trying to seek care. And in too many systems, that information that they get about the specialist from the primary care doctor is coming from a print directory that may be out of date the second it's printed. They're going online to do some research and looking at information that's maintained by a different team within the health system. And finally, when they call into the call center, they find out that person doesn't even work there anymore because the operations team actually has a more current directory. And so it's essential, and we actually often coach our clients early on, that the very first step in this journey is really organizing the data so that there is the ability to have a consistent experience across all these different channels. Claudia, have you advanced one more? So if you think about what you're trying to enable, it's really being able to accommodate different preferences for patients that may be changing with different conditions. So someone may be more comfortable seeing a female provider that speaks their language. They might want availability on a morning that they've got daycare coverage. Obviously their insurance is a critical, important part of that. But the providers are all different as well. They might take different insurance products in different offices. They might have access to different kinds of equipment, and they may have a sub-specialty that is very important for them to be recognized for and to see patients for that. And the final piece that we spend a lot of time talking with health system leadership around as well is the strategy of the organization and how to begin to operationalize that through the digital front door. And they might want to think differently about employed physicians versus affiliates, new doctors that have a lot of availability versus those that may already be booked out for several weeks. And as they think about fee for value and fee for service, how do they think about navigating patients around their provider network? If you could go forward one more, Claudia. And so for us, it really starts again with that underlying data platform. We bring a scaffolding of a directory to our engagements with health systems, but a lot of the work we do over the first 3 months is really integrating data from dozens of different silos and really pulling together about 200 different data elements about each provider. So a personal statement, a picture, but also their scope of practice, the insurance, whether or not they're accepting new patients or not. And there are really two steps that go into that. One is the data integration itself, and that can be challenging because I might be Graham S. Gardner, MD, in a marketing database, but I'm Dr. G. Gardner in a different database. And so reconciling across 8,000 physicians, all those identities can be some work. But the second, probably even more important part of this is really the governance around that data. So for example, a location field might be sitting in my credentialing file, but that only gets updated every 2 years when I re-credential. It might be in a marketing database that gets updated every 6 months when there's an outbound phone call that happens to verify that I'm still there. But it's also in the practice management system where I'm seeing patients tomorrow morning. So a lot of the work that we do is really understanding what's the most current and accurate source of that information and really setting up all the feeds to maintain an ongoing directory of care. We then enrich that directory with a clinical library of about 20,000 terms that are all crosswalked to about 500 different subspecialties of medicine. So that we onboard an organization, we identify who the peripheral interventional cardiologists are, and they get pre-assigned a set of terms that define a typical scope of practice for a provider. We then work with that provider, the clinical leadership, or sometimes the practice administrators to further curate that list so that we now have a term level way of routing in and out of each different provider schedule. And the final part of really becoming transaction ready is enabling real-time scheduling. And as many of you, I'm sure, know, there's a lot of complexity in underlying schedules. We often will find organizations with thousands and thousands of different appointment types per EMR and oftentimes with multiple EMRs. And so we've really developed a lot of tools to crosswalk all of those appointment types into very simple consumer language so they can understand this is a new patient appointment of this duration and be able to book on that without taking out all the rules and logic that are in the underlying EMR system. Then what we do is to publish that information into different areas of the health system where scheduling is being done. So call center agents have access to that information and can do real-time scheduling for a patient on the phone. Consumers can self-schedule through the Find a Doc, and then anyone else out in the network, whether it's a referring provider, urgent care provider, can also, again, use the tool to search by keyword, find and route a patient regardless of what underlying healthcare record the physician is using. And then the last slide here, Claudia, if you could advance, just shows the paradigm that we're trying to enable, which is really allowing a health system and its providers to be discoverable. So using all of that rich content, optimizing for search engines, using listing management services to broadcast that information and attract patients into the system. Allowing them then to navigate through that information and define what is right for them, whether it's a location, a time, or a certain clinical condition. And finally, allowing a transaction to happen in real time that can be trusted and integrated into the underlying workflows of the health system. So I'll stop there for now, Aaron, and I'll turn it back over to you.
Thanks, Graham. Go to the next slide, if you don't mind. Yeah, so now we're going to kind of like focus on kind of the same-day care part of our platform, something that we've called Dex Care. And so just as by way of background, Providence has incubated and several different technology companies, one of them being Zelt, another was sold to Wildflower Health. This is our third incubation, Dex Care. It currently has us as a health system as a customer, and 2 other health systems as customers as well, and we're looking towards another couple of health systems are signing on in the next 60 days. If you can go to the next slide. Keep going. There you go. This is what we mean by same-day care. It's digital self-service, always available. It's a low transparent price, and it provides multiple different care options. In our world, it's urgent care, retail clinics, in some sense, primary care, virtual care, and at home. It sounds easy. It's hard to do. Basically, a big part of this has been in our world is organizing around a big business strategy. So our consumer-facing brand is called Express Care. We have over 40 locations now in the Puget Sound area, Oregon, and then we've just launched in Alaska and Southern California. And the format of Express Care, for instance, is sometimes it's in a Walgreens clinic, in a Walgreens retail location, and sometimes they're standalone, but they're nurse practitioner staff locations. We also are fortunate to have, I think, the third largest retail urgent care footprint in the country, and then we also have close to 1,000 clinics out in the market, most of which are primary care clinics. And then finally, we also provide virtual care, so virtual visits, and then you can, in the Seattle market, you can summon somebody to your home using this technology platform. So go to the next slide, please. What we learned and why we invented this technology, given the fact that there are various different point solutions out there, is that we kind of started down the path of trying to use our EMR, which is Epic, and add to that virtual visits through another vendor. And the challenge that we kept running into is we couldn't get kind of an integrated experience, so the user experience was bad. It didn't really support the business model we were trying to stand up. And so we'll talk a little bit, about some of the platform that we kind of built to optimize the business model. We didn't really have kind of, brand and control over the patient relationship. And the way that it was priced with the vendors was also misaligned. We, for instance, were being charged effectively a flat fee that was very, very high for virtual visits, that if you took it on a per virtual visit basis, you could never make that business model work out, as one of many examples of how the pricing was set up. And so the team, after kind of trying to kind of make this work for, about a year or so, kind of took out a blank sheet of paper, and we kind of came up with the Dex Care value proposition. Go to the next slide. So what we built was effectively a seamless user experience price alignment across all the same-day care alternatives, to where, when we're pricing it to ourselves or to our other health system partners, making sure that the pricing is rational and it doesn't vary per transaction, whether it's a scheduled event offline or a retail visit or a video visit online. Basically giving us full control over the brand and our patients, and so there's a single kind of identity layer that patients log into, and then also kind of building it to where it kind of supports the same-day care business model, which is a very challenging business model to make work. Go to the next slide. So what it does is it's turnkey, so it unifies all the modalities of same-day care, single seamless user experience, and then it drives growth through new patient acquisition, specifically commercial patients, efficiency and engagement. Go to the next slide. So going kind of from left to right, when you start with the consumer, what we start off with is a SEO, SEM locally optimized platform that really kind of leverages and shows up well in Google, so that patients can quickly find care. They then go through a scheduling process that creates as little friction as possible to convert the patients into a new patient. When they're ready for a virtual visit, for instance, they can either go into a clinic, summon somebody to the home, or they can do a virtual visit. When they're doing a virtual visit in the waiting room, we also do digital registration, online payments, and we have a symptom checker chatbot that does a lot of the pre-work prior to the nurse practitioner seeing the patient. And then in the actual visit, you can do in-person in a clinic, virtual, or we'll come to your home. And then afterwards, we support an SDK into our Providence Health Connect, which allows us to, once we capture the patient, into our ecosystem, to continue to engage with them with an iOS and Android application. So it's very analogous to the way that a lot of my team came from Amazon, Expedia, Microsoft, places like that, and it's no different than how the travel and accommodation platforms out there work. Is they try to reduce the amount of friction as much as possible, make it easy to have the consumer discover the service, and then convert them into an experience in which they can further kind of promote engagement, so that they don't constantly have to reacquire that patient the next time they seek care. Go to the next slide. This is a platform overview. So we kind of talked a little bit about the front end. There's a seamless experience from discovery to delivery, as we just discussed. For the provider, there's a virtual care delivery console. And for the health system, we have a suite of marketing and analytics tools that helps you kind of optimize the conversions. It helps your marketing team really dial in the experience of SEO, SEM, and local. Then the big kind of, part of the technology that we spend a lot of time on is how to optimize the platform, to go from kind of, to get into effectively treat each appointment as effectively inventory to be filled and optimized. And how we do that is that across the 43 different locations that we have, every patient that is seen virtually can be slotted into an existing scheduled appointment. So you can have the situation where, a provider is sitting at a Walgreens clinic seeing a patient in person at 10 o'clock. Then at 10:20, she may see a patient from anywhere in the state, through a virtual visit. We also have a platform, part of the platform, that does resource forecasting. So every single year, we kind of have started to learn what the curves look like in terms of the ramp up around flu season, so we're able to kind of staff effectively. And then we've also built digital registration and payment. We've launched some of our first, what we call MA-free clinics, to where only the nurse practitioner is staffed there. And again, it lowers the amount of labor that we need to kind of support a single clinic. And we can put more clinics out into the market, and then be more pervasive in terms of our care delivery. And then finally, on the back end part of the process, we've got an identity management layer that hooks into the EMR. We integrate into the EMR so that there's a seamless clinical experience. So if they're referred, they don't have to go through, two different systems. And then we've also got a set of marketing optimization tools that allow us to kind of lower the cost to acquire each of these new patients. Let's go ahead and, So we've seen some really great early indicators of success. This platform has been up for a little bit over 2.5 years now. It's scaled pretty dramatically. And as I said, we now have a little bit over 40 clinics. We're going to add another 40 to 45 down mainly in Southern California over the next year, and then expand beyond that. But the key metrics that we care about is about 65% of those patients that we see are coming through a self-scheduling experience or a virtual visit. 73% of those patients are commercially insured. 30% of them are new to us as a health system, which is amazing because we tend to be either number one or a close number two in every single one of our markets. And so the fact that we're getting that high rate of new patient acquisition is pretty amazing. About 1.5 times of the revenue that we collect upstream in the clinics, we see 1.5 times that downstream in terms of primary care referrals, specialty, and procedures. And then we're seeing an 82 patient NPS score. Our patients love the platform. Just to give you a benchmark, if you're not familiar with NPS, Amazon typically rolls, and Apple typically runs kind of between 60 and 70 NPS for their products and services. So we're really, really kind of batting great. And then 10% of the visits that we're doing are video visits. So these are actually truly video visits where care is delivered over a video conferencing platform that we've built, which is a very high adoption rate of video visits that we've seen, kind of across the industry. Next slide. So I think that's it. I will point out that Graham and my pictures are reversed here, so I got the better end of that deal. So,
oh boy!
We look like twins there.
Well,
yes. So I apologize profusely for Graham.
Oh boy! Well, I'm glad you liked the switch. And anything I can do to please you all. Well,
if only I can look like Graham. That's what.
Thank you so much. That was really so interesting. I'll start off, Aaron, with you. When you first started this project, what were some of your key priorities that you were thinking about in terms of this initiative for Providence? What were some of your expectations, and why did you decide to launch into this in the first place?
Yeah, so just by way of background, I worked at Amazon for 9 years, and then prior to that, I started a couple of companies in technology and banking, financial services software, and manufacturing software. And at Amazon, a big part of my job was to disrupt the publishing industry and create kind of a new value proposition and collapse the value chain between authors and their readers by creating a self-publishing platform. So one of the reasons why I joined Providence is our CEO and our president of operations, our CEO, Rod Hockman, and our president of operations, Mike Butler, recruited me. And what impressed me about them is they said, look, we need to kind of disrupt our own business model. If we don't do it, somebody else will. And we, and we figure if we kind of get involved in self-disruption, then we have at least got to stay in the future, and which is absolutely true and right on. And so when I looked at our business overall as a big integrated health system, it was clear to me that the thing that could first go kind of wrong is because we have this cross-subsidization model in healthcare. If we lost our commercial business, then we wouldn't be able to fulfill our mission. And so really where we first kind of started off is like, how do we build a really great value proposition from a digital experience standpoint for those patients so that we don't lose them to these disruptors. And the other thing too is like, I was pretty sure that the first place that, these disruptors would go for would not be, our Medicaid population. They would be going for our commercial population because of they're the highest margin patients in the marketplace. And so it was really incumbent upon us to be able to kind of fulfill our mission to kind of protect this business. And so when I first came on board, Rod Hochman said, "Hey, congratulations, we've got this great new commercial client. We need to, build a website within, I think 60 days or something absurd like that. And we've got to do it or we're going to be under technical breach." And so I looked at what, websites were available, for providers out there, and I saw kind of content and, physician directory. And so, of course, the story I always tell is I went to our CIO and said, well, clearly there's got to be some source of truth for all of our physician data, and this is back in 2015. And, she was, kind of a long history in healthcare, a wonderful woman, and she came up to me and she said, kind of patted me on the head and said, "Welcome to healthcare, Amazon boy, it doesn't exist." And so real quickly, I started kind of looking for that solution and got connected to Graham and his team, and they were able to not only deliver the physician directory and the website, but since then are powering 100% of our close to, I want to say, almost 30,000 employed and affiliated physicians across our eight states.
I mean, it's been a fascinating process, and congratulations. I want to go back just for a second before several people are asking questions on the Q&A, but I want to go back to just a statistic here, if you could explain the patient NPS. I'm not really clear on what NPS is, and you mentioned the number 82. It seems like that's a pretty good number, but could you sort of explain that a little bit, and in terms of what your expectations were in the first place, is this sort of exceeding what you were initially thinking it should be or could be?
Yeah, to give you an idea, most of healthcare is like 10 or below. So, healthcare does not have a reputation for having a high NPS score. And what NPS is it's a cross-industry metric that is generally used for kind of measuring patient satisfaction. And perfect is 100. The worst score you can get is -100, just to give you a scale, and 0 is kind of in the middle. And unfortunately, most of healthcare is kind of in the low single digits. Great technology organizations like Apple and Amazon and folks like that kind of score in the high 60s, just to give you an idea of the scale of this. And what it measures is your likelihood to refer the service that you just experienced or the technology you just experienced, the product you just bought to somebody else So it's the likelihood of referral.
Thank you. And just before we go into the Q&A with the participants, I wanted to ask Graham, in terms of joining with Aaron and Providence, how does Kyruus merge in with the Providence EHR and obtain the kind of information, in terms of the providers and the specialties and also the patient information to make sure that all is exact?
Yeah, it's a big question there, Claudia, but I'll just first and foremost, how lucky we were to find Aaron, relatively early on in our company's journey. And I think what he represents, and as so many people know him as a thought leader, is someone that really understood technology and technology best practices from other industries, but also had a great deal of humility in coming into healthcare and recognizing that we weren't behind because we were stupid. It's actually very, very complicated, and began to really paint a vision, I think, for many of his colleagues around the country of where we could go. And so we're very fortunate to join with him and have him appreciate the journey journey that companies and systems go on together in getting this right. And so I think from very early on, we were very transparent about what each organization was good at doing and wanted to be able to do, and had a very kind of collaborative nature associated with that. And I think the story, which remains very much the case with organizations around the country today as well, is that we often will phase things in. And so, again, the priority first and foremost is getting the data right. And so the first 3 months or so of our engagement is really working with stakeholders across the organization in marketing, operations, and finance, and HR, understanding where the data sits today and bringing it in. I think in many of those, especially the early engagements, it's often very surprising to organizations just how bad the data is. Many of the data fields are empty, and so there's an iterative process, and sometimes a lot of engagement and retooling that goes into bringing that directory together. And then, the rest of the journey is as much a cultural one as it is a technical one. And I think, for many providers, especially when we started several years ago, the idea of someone booking into their schedule online was actually a very scary thing. They have, put up a lot of defenses, understandably, because you want to make sure that you're getting the right kinds of care. And I certainly saw this, when I was practicing as well, that a patient would come into the clinic and say, hey, I'm here for my, palpitations, my rhythm disorder. And you have to say, look, I'm really sorry, but I'm actually not the right kind of cardiologist. I'm going to need to re-refer you back to one of my colleagues. You're going to have to wait longer and pay another copay to get in there. And so they developed a lot of mechanisms to protect both the patient and themselves and try to ensure that the right kinds of cases were getting in. And so a lot of the way we built the tool with the things like the clinical library have really had a physician engagement piece as part of that to make them feel like, look, we're listening to them and understand exactly how to get the right kind of care. And that allows you then to ask for permission, basically, to centralize scheduling in a call center that's away from their front office staff, or to enable a consumer to book online. And even that journey with organizations sometimes take time. We'll start with the primary care, maybe some dermatology, OBGYN, and then phase in other specialties over time. But then, the goal is obviously to get everybody in the organization, both the employed and the affiliate, all on a single bookable platform where patients can really access care.
Well, actually, that leads into one of the questions here from the participants. What are the adoption rates of the digital front door with the elderly population? Both of you, I guess, could respond, please.
It's an interesting thing that the highest growth rate, not surprisingly, in digital is folks, kind of at retirement age, and it's not surprising because folks have kind of grown up with digital and are kind of aging into retirement right now. And so it's just kind of a misnomer that, that digital it's because, like last time I checked, everybody gets older. And so, kind of the population, and especially the baby boomers, are kind of aging into, taking their digital tools with them into retirement and into the Medicare, space. That said, one of the things that we're starting to kind of think about is, some of the convenience aspects of this to really kind of serve that population, especially duals. So we started off kind of, with this digital platform fundamentally focused on the commercial population because they're literally, standing outside of our proverbial digital front door waiting for us to get our collective acts together so that we can serve them like they see us in, like every other, service that they deal with in their daily lives. But that said, we're starting to kind of tweak the platform to kind of better serve the Medicaid population, the Medicare population. And what I'll say is, especially with the kind of lower income, vulnerable population, inconvenience hurts them way more than it does middle and upper income. And the reason is because if you're taking kind of, if you're being forced to go to an EED, for something relatively minor, that is going to be very, very expensive, not only for, the health system, but for you personally, potentially. And then also, if you're forced to either wait or take half a day off of work, to, to go see a primary care physician for something that could be seen, in a virtual visit after hours, you're taking half a day's of wages off in addition to the expense of the clinic visit. So we're also, very, even though that we've kind of started off kind of focused on the commercial population, we're starting to kind of change and modify the platform in more and different ways to make sure it's serving every population in different ways.
And Claudia, I would say, one of the explicit filters we often will put up for health systems is actually age group for the patient, and we see usage across all that directly by patients, and also I think, and Erin talks about this a little bit as well in terms of the mother in the family scheduling both for her children, but also potentially for the parents in the family, and seeing a lot of the baby boomers scheduling for their elderly parents and stuff like that. So it really is useful for every age group.
Thank you. So it actually leads into the next question. With new care delivery models such as DexCare, have there been challenges with payers and getting billing aligned with new care delivery?
It's interesting. In our markets, it's been, I think the team that runs Express Care would say it has been a huge challenge initially, but once we kind of broke through in Washington, Oregon, and then now in California, it's been a lot easier to kind of get, for instance, virtual visits paid for. And we're even kind of making progress in the Medicaid population with the states, which is a huge, huge benefit. So I would say, we've been doing this for kind of, going on 4 or 5 years now. The original push was really, really hard to get kind of reimbursement codes and that kind of thing, but now it's kind of leveled off. And the reason is there was an initial concern that it would drive overutilization, but I think what they figured out is, the payers have figured out is that the increased utilization would have to be 2 or 3 times for it to even kind of, for them to be worse off, right? Because of the much, much lower expense of a virtual visit.
So what are some of the challenges that you face today in terms of interoperability and having a seamless digital platform?
Oh, goodness. I think we've kind of solved for it between the, kind of the low acuity area and into primary care and specialty. And the way that we've done it is we've integrated directly into the EMR. And then what happens is once you have one of these virtual visits, or you go into one of these clinics, it's a simple matter of referring them within our network of care through our EMR. So there's not a whole lot of friction, from that point of view. One of the things that, Graham and I talk about constantly is, what do you do, especially in the physician network? And we've got a huge challenge in Southern California because we have a very kind of broad CIN there that, we don't employ any physicians in California, and even the ones that are in the foundations that we're aligned with aren't the majority of the physicians that we work with down there. And so one of the things that Graham and I have been talking about is how to, get them all on kind of, to be bookable, for instance, even though they're on kind of a random assortment of smallish EHRs, right? They're not all on Epic or Cerner or Athena. They're on many, many different physician practice systems. Graham, do you want to talk a little bit about how you guys have solved that problem in other markets?
Yeah, happy to, Aaron. So I think, fortunately, Claudia, many of the larger EMRs, Epic and Cerner, are actually developing, good tools to enable operability. They have different programs that companies can join that help facilitate, sometimes even through API access, into the calendar. We have a different solution that we apply to the long tail of very small EMRs that allows a very simple overlay, so those providers can still be accommodated within the network. But for most of the EMRs, we actually have pretty robust taps into those systems. I think the part of the question though too, we've been talking about interoperability for so long as in terms of EMRs. But really a lot of what we see also happening is the creation of a vertical digital stack of different kinds of technologies as well. And I think folks like Aaron are really beginning to think about a comprehensive strategy around CRM, telemedicine, ratings and reviews, transportation. And so one has to begin to think about interoperability within that digital stack as well as just the EMRs. And a lot of the work that I do personally actually is working with our ecosystem of business development partners to make sure that we're seamlessly integrated into those other companies so that we can really de-risk those implementations for our customers.
And with the growth that we're mentioning before with adding on so many different clinics, how does Kyruus, how do you keep all the providers and all those specialties current?
So the first step is really, again, understanding the source of the data and then setting up feeds that allow us to stay current with that. So we, in many cases, do not replace any underlying systems. So credentialing exists for its own purposes. The PeopleSoft and HR exists over here. Marketing has a database over there. We need to pull elements from each of those, but we're not going to replace those because they have workflows associated with those different functions. And so it's identifying where it should come from and then figuring out the cadence from which to pull. So for example, you may only need to pull from credentialing on a nightly basis because it's really only that frequently that new providers are added. However, the scheduling has obviously got to be real time with race conditions. So just like buying a concert ticket, you make sure you're not booking over the same slot. So we do a lot of the work in organizing that, Claudia.
And so going back to DexCare, how does DexCare compare to some of the different point solutions such as scheduling or telehealth, et cetera, that you all have stitched together?
Yeah, I mean, the big challenge that we had for the first kind of couple of years while I was here trying to figure this out was, we had our EHR doing kind of scheduling. There was a problem with kind of exposing that and kind of exposing that in an effective way and marketing it effectively through SEO, SEM, and local. There was a hard time, we still have a hard time getting kind of data from kind of the top to the bottom of the funnel so we can see conversions. And then there was the challenge of having multiple kind of logins, and so then you have to kind of implement an identity layer on top of it. And then even with all that, it was really, really hard to kind of iterate quickly with both the EHR vendor and the telehealth vendor to get to the point to where we were taking enough friction out of the transaction to convert a reasonable number of patients to where we could see that the business model was going to work long term. So it was a combination of, we're just because there's equivalent functionality doesn't mean it works well together. And one of the kind of concepts that we brought over, most of my team is from Amazon, is we brought over two things, one that Amazon is famous for and another one that few people recognize that Amazon does well, but it's something they do really, really well, which is, the first thing is we always start with the customer and work our way backwards. And so we started with a blank sheet of paper and thought about what does the consumer want from a same-day care experience? And we worked backwards from that and kind of built the platform this way. And then the second thing is that, below it, and most of where we kind of made investments in the technology is how are we going to optimize the operations using technology to make sure that we can build and launch these clinics in the telehealth platform and operate it profitably, which those words are typically not used in the same sentence in primary care. And so what we've really kind of come up with is a platform that saves money because it moves a lot of the work around scheduling to the patient, where the patient can do this self-service, number one. Number two, creates, it attracts these very economically valuable commercial patients in a very favorable mix. Number three, it lowers the cost of acquiring them. Number four, it lowers actually our physical footprint. And so we have estimated that we probably would have had to launch 2 or 3 additional clinics if we didn't have the virtual visit capability that we have now, to kind of, serve those patients. And then, the fifth thing it does is it creates a connected care experience, so it integrates into the EMR, and so once the patient is kind of, has seen somebody in one of these clinics or in virtual visit, it moves them, if they need to be referred into primary care or into specialty or into a procedure.
It's just been fascinating. So, in terms of the virtual visits, how have you found, and do you have actual statistics on how it has made significant difference in improving patient engagement?
Yeah, so we have very high repeat usage rates, number one. Number two, the key thing is make, step one is to make the transactions, whether, again, typically patients are looking for two things when they're ready to transact, either a same-day care experience or to set up a relationship with a patient. Same-day care, we use DexCare. Set up a relationship with a physician, I should say, we use Kyruus. Once they've had that first, transaction, then the key becomes, all right, how do we engage with them between now and the next episode of care, so that we're always top of mind as their care provider, so that we don't need to go out and spend marketing dollars to, to reacquire them, so they're going to naturally come back to us. So the first thing we do is we encourage them to download the Providence Health Connect app, and then within the Health Connect app, we are sending to them helpful, content. They are able to access the EMR through, their MyChart account. They have a single login, so they don't have to remember their MyChart credentials ever again. And then they also are constantly getting kind of updates and feeds that kind of are working to kind of keep them healthy and keep them engaged between episodes of care. So again, it's not too dissimilar from other engagement programs like, where I came from, Amazon. They have the Prime program. That is a very good and incredibly effective example of an engagement program where, what Amazon was doing is they're trying to figure out how do they increase the percentage of your wallet that you're going to spend on Amazon. And the way they did that is to keep you engaged by taking off the cost of shipping off the top. So they basically did that first through free 2-day shipping. And then they added movies and music and those types of things, giving you reasons to come to them and continuous engage with them, so they don't have to guess when you're in the market next for a book or a blender. It's the same thing in healthcare, where we want to be constantly engaged with the patient between episodes of care around their health, so that we're making them healthier and teaching them how to be healthier through content. B, we're able to capture, opportunities for engagement that otherwise would have just gone into the wind. So, with the Zelf platform, think of how many times a physician makes a recommendation of some product or read this article or whatever, and it's just simply a piece of paper handed over to the patient. In this case, we make it easier for the physician to make the referral or to make the recommendation, and then the patient comes and picks it up in our digital front door, and so while they're there, again, we can continue to educate them on, the various different health matters.
So we're getting close to the top of the hour. We'll answer one last question, and that is, do you believe there's opportunity to leverage artificial intelligence or machine learning to continue to optimize the platform and improve the connected care experience?
Definitely. I'll comment real quickly, and then I'll let Graham comment real quickly. On the DexCare side of things, we're already doing that. So we use an AI bot right now to help navigate you to the right venue of care based on the condition and your location and your insurance, et cetera, et cetera. So we're doing that today. We're also doing pre-visit work to help you get you ready for the visit, and also kind of set up the visit to be more efficient, in virtual visits. I think over the fullness of time, as we start to scale this, you can see more and more, it's going to be a partnership between AI and humans to serve the patient better. Graham, comments on your side?
Yeah, I would agree entirely, Aaron. I often will use the airline analogy when talking about Kyruus, and the same way that a kayak or a Travelocity allows you to look across a digital inventory of different providers like American and Continental United. We allow you to look across different EMRs and search and filter the same way, and ultimately book a seat, if you will, within the health system. One of the things that the airline has gotten very, very good is managing all the preferred seats and when to hold a first class, when to release it, to upgrade it, and things like that. And I think the analogy, which is maybe stretching a little bit, but we think about is acuity of patients. And if I'm a 25-year-old who's been lifting weights and has chest pain, that may be very different than a diabetic with a stent last week that has chest pain. And so how do you begin to leave appointments open to accommodate urgent visits, know how to predict when that's going to happen, what kinds of things can be kicked out to telemedicine. I think that artificial intelligence will play a huge role in really operationalizing and streamlining that.
Well, I want to, on that note, I guess it's the end of the hour, and I want to thank the presenters, Aaron and Graham, so much for such an interesting conversation, and all the people that participated on the webinar. So Aaron, Graham, thank you.
Thanks for having us.
Thank you.